another great friend, Dr. Butler. He needs no introduction to those of us in the room, but for those of you listening in around the globe, Dr. Butler is a professor of emergency medicine here at the University of Maryland Department of Emergency Medicine and is truly an internationally recognized expert in advanced airway management. Ken has been teaching advanced airway management really since he joined the faculty, I believe, 1994, around then. Around then. Yeah. And he has traveled the globe, has won countless awards, and he is our airway go-to expert, our airway guru here at UMEM. So there have been some articles over the last, say, 2 or 3 years about specific controversies in RSI medications, things that we use every day. Perhaps the overnight team used them last night to intubate patients in the emergency department, critically ill patients that needed airway management. So to bring us up to date, to talk about some of those controversies in RSI medications, is Dr. Butler. Welcome, Ken.
First of all, I want to thank Mike for asking me to lecture. I'm hugely honored to do this. Okay, you know, I looked at that slide from a distance, and that kind of scares me if all those people were hanging over my head, but I'll let that go for now. Okay, I have no disclosures, so let's get to it. I only have you for a half hour, which kills me. So this is my slide. We're done. I can leave now. This is the team. I have faculty who will remain nameless because one of them is not here. That is a diehard ketamine person that has ketamine bed sheets, bumper stickers, blah, 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 and then the etomidate team. So maybe I can shed light on these two drugs when we get to induction agents and have some fun. And I think the opinions are very strong, and I respect that. But I'm going to tell you what's hot off the press. If you listen to or read the articles such as I do, this article that came out, this just came out last month. This is Journal of Critical Care. They looked at ketamine versus etomidate as an induction agent for tracheal intubation in critically ill patients. And Rory talked to you about what a Bayesian analysis is. This made tremendous waves in the airway literature. And I happen to like some of the people that talked about it, but I'll get to this article in depth a little bit later. But what they did is they compared ketamine to etomidate, and they said that ketamine was associated with a decreased risk in mortality. That's a great word to read. I would like that if I was the person getting induced. I happen to like Journal Feed. I'm not part of this. Journal Feed is on my email. And Journal Feed said this, I quote this from my email, that ketamine for the win. Big word to say, right? So it's basically poo-pooing anything we had about etomidate. If you look at the numbers from this article, it says that there's an 83% probability that ketamine decreases the risk of mortality. That's a huge number compared to etomidate. So I would put the pendulum back to the ketamine, if that's true. But we'll see this. So before I even talk about this, I mentioned this in Amel's conference that we talked about in cardiac critical care in the past, but airway articles are very difficult to interpret. And hopefully I'm going to show you the comparison of those articles compared to other procedure articles of why they're so complicated. And they are because there are so many variables when you look at an airway article. In no other articles would do this. And we'll walk through these. You would need all the patients in this particular study that looked at septic patients to have the same underlying illness, whether that's gram-negative, gram-positive, or fungal. That's not happening. Number two, you would need the same duration of that illness. If you're well-read on ketamine, there were articles that patients that were septic for greater than 24 hours that got ketamine and cardiac arrested. The thought is because of the change in catecholamines from ketamine, that maybe in prolonged sepsis, ketamine may be a no. So I don't have that data. I'm just making a comment to you that you need duration of illness when you look at septic patients and induction agents. We're so not done. The patients would have to have the same anatomy. And the reason why I say that when we talk about the intubators, this is going to come back up in a second. You would have to have this same cardiac, pulmonary, vascular, immune, and metabolic reserve. I love saying that word. Who knows the patient's underlying immune system, their pulmonary reserve? Maybe you're great at ultrasound. I'm not. Lean is here that teaches me that at the bedside. I don't know their cardiac reserve, if they're going to dip their blood pressure or not when I'm getting ready to intubate, especially if the patient can't give me their history. Okay, and they would also need to have the same bacterial infection in septic patients if you did cultures on them, another impossibility. And they would also need the same reaction to drugs. We all look at drugs differently and react differently to them. How did they react to the induction agent? How do they react to the paralytic? Patients react differently from even same doses, as we all know. This is my pet peeve when I look at airway articles. You would need to have all the intubators having the same experience. I've read many articles that even talk about PGY 1 through 4 and attendings, but it never tells you that individual's frequency of intubation. The residents that are here know that we intubate weekly here, but throughout the rest of this country and overseas, those people may only intubate maybe once every so many months, so their experience is much less than yours. They're not going to be good at a difficult airway. Of course not. Their experience is low. So be careful what you read when you look at intubators' experience. There's no question about that. So at the end of the day, the data on this is really suggestive. I love that word. So paralytics, we look at sucks versus rock. So we'll make some comments on these too. I'm going to teach you this. Rocuronium has a 40-second longer safe apnea time. What does that mean? It means that when this paralytic is given, the patient doesn't desaturate. And this comes out of pharmacology's data more so than it does at clinical data. So they don't desaturate at all to the less than 88% in that initial apnea time. And the point I want you to remember is this. Sucks causes this decrease in safe apnea time because it requires O2 at the myoneural junction to form paralysis. So it takes O2 in to give you that. It also raises CO2 levels. Because of those fasciculations, you remember that when you were an intern back in the OR, and maybe they did switch monitors and so forth, because when muscles are twitching, for lack of a better word, it releases CO2. So if you're intubating someone who's profoundly acidotic, sucks is not your friend when it comes to that, because it will raise CO2 and drop your pH. So kind of a poo-poo on that. It also, when sucks comes out, meaning when you come out of paralysis, it also uses oxygen as a catalyst. So it takes O2 in, it takes O2 out. I don't want a drug that does that. And you all know that that's one reason that we don't use that amongst many. So it's not your friend. So rocuronium is much safer for potassium. There's no question for that. If you read the articles about intubation in patients that had a small bump in potassium, all those patients that I've read were done in the OR, pre-op. None of them were septic, none of them were acidotic, and more importantly, none of them were in renal failure. And people that require intubation early, you won't have time to get labs back. That's our longest thing. We don't know that. So that little bump in K, if you're intubating in inner city medicine, is not going to be your friend. I like this because the duration of ROC lets you equilibrate the vent settings. Pulmonary loves it when there's an ease, I love that word, of ventilation. You can't do that if patients are coming out of paralysis, not your friend. And the data is pretty clear in traumatic brain injured patients because succinylcholine causes a peak and trough of your blood pressure. It also causes a peak and trough of your cerebral perfusion pressure. So not a good outcome on those patients. But more importantly, this is the money. If you've had enough difficult airways under your belt, and I hope that you have, not for your patient's sake, but for your clinical state, that the duration of sucks is always your benefit. Why is that? Because if you failed the airway, you have a higher rate of ease of using bag ventilation and also a supraglottic airway, or even if you got to a surgical airway. You can't do that if you have to redose a patient in sucks. So it's clearly your friend for that reason. Makes me happy. I'm fortunate enough that I've done airway labs and lectures around the world. I love this. My friends from Australia sent me this from Sydney. Look at this. Here's the word never. How do you know the word never? You're supposed to look at these 5 diseases and say you can never give sucks on that. We can't use the word never here. I would go back to HR, and they know me by my first name down there. Moving forward, patients that are guppy breathing and can't talk, you can't get any labs, so maybe you have no access to their medical history. In Australia, you can never give sucks to those patients. I love this. So I would take that off the table. In other countries, unfortunately, rocuronium costs a little bit more money than sucks. That's an issue. For my friends that have emailed me, you can always go to high-dose VEC, and I'll leave that as a whole other conversation. Okay, let's get to induction agents. This is what my slide is all about. Ketamine people. Ketamine people are diehard. Why? They don't want to drop somebody's blood pressure. They're anti-etomidate because they're saying, well, maybe you have to give them a steroid chaser to block this potential risk in getting adrenal insufficiency. Well, let's see if that's really true or not. So let's go forward. We have to talk about peri-intubation hypotension. This is what you're trying to abort through all these drugs and during your intubation. Maybe I can make it easier for you. Doreen told me that we have many people that have logged on, and Dr. Winters from people from other countries. I love this study. This was just JAMA 2021. They looked at almost 30 countries, to look at the risk of cardiovascular instability when patients were intubated. And almost half of their patients did, and many of them also cardiac arrested. This was followed up by American Journal of Emergency Medicine just last year. They said the same thing. This was the prevalence of peri-intubation adverse events in critically ill patients. They did a meta-analysis review. In their study, peri-intubation major adverse events were up 30% of patients. And the bottom line of this article was that 1 in 3 patients dipped their blood pressure, and a significant amount of them cardiac arrested. Your patients are more sicker than my patients were when I was a resident. So you need to know this, or what can you do to abort this? That's the money. So somewhere, depending on how lucky you are, it ranges from 5 to 45%, right? And we're worried about hypotension because if we get decrease in perfusion, we're going to have a bad outcome, decrease brain, cardiac, renal, and the risk of cardiac instability remains high, even if they dip their blood pressure for a short period of time. Okay, we get this loss of an adrenergic tone, maybe from the paralytic and the induction agent together, which compounds the problem. We all know that. That's why I said you would need to know the patient's vascular reserve before you do this. And you can't really tell that by just ultrasounding somebody. Maybe you can look at their EF, but you still can't determine their vascular tone per se. The other issue is this: if patients that are severely acidotic, you made them apneic from your drugs, whichever ones you choose, you're going to raise their CO2, decrease their pH. Cardiology teaches me that patients that are profoundly acidotic is a cardiac irritant. So you're in a lose-lose box in this window of time. And I don't want you to be there, clearly. And so we have this direct effect from the induction agent and the paralytic. What can we do to do that? We know about bagging a patient, decreases their preload, but now not only do we have a decrease in cardiac output, but we have a decrease in adrenergic tone from either the paralytic or the combination of both. We don't want to do that. So how do I predict who's going to crash? Well, I happen to like this, and it's underutilized. Your patient comes in, can't talk, can't breathe, no history of any medical record because you don't have an ID. You may be in another country that has no access to anything, maybe not even an IV yet. You would look at their shock index. I'm fortunate enough that EMS calls me on the radio and gives me their heart rate and blood pressure. Boom, I can remember this. I could say this patient's at risk to have a bad adverse cardiac event from intubation. I'm not good at remembering numbers. I'm too old to remember that, but I do remember this 0.8 is the money when you look at patients that are at risk, and patients that have a shock index of greater than 0.9 have a highest rate of cardiac arresting from intubation. So you get the radio, you have their blood pressure, you have their heart rate. How do you remember 8s? I remember this maybe from playing billiards back in New Jersey. I don't want you to get behind the 8 ball. So if you can remember 8 is your bad number when it comes to looking at shock index, you're going to at least be ready to go. Love that. Okay. Association of Shock Indices. This is Journal of Intensive Care Medicine. This year looked at shock indices. This is the PACE trial. You don't need to remember that. What you need to remember is they said, and I quote, that shock indices remain a useful bedside tool when calculating or predicting peri-intubation hypotension. So please use it. It's going to help you out. It takes you 2 seconds to figure this out. Okay, what's on the table of my lecture? These 3 are on the table. You guys all use them, love them, maybe hate them, I don't know. But I'm hopefully shed a light on these 3 on what I think you should remember. Each of these agents has advantages and disadvantages over the other. There's no question about that. And I'll tell you who's better than not. Let's start with propofol. I personally don't think propofol is in the R of RSI because of its rate of dropping somebody's blood pressure. We all know that it decreases cardiac indices. It's a myocardial depressant. Please remember this, that it has independent beta and calcium channel blockade. Patients that can't talk, elderly, maybe on hypertensive meds, giving this medicine initially is going to drop their blood pressure. Yes, anesthesia lives with phenylephrine in their back pocket. You don't. So I'm not going to abort this right now. So I would take that off the table, except for one type of patient. Here's the deal. Neurology, neurocritical care, loves the combination of ketamine and propofol together for status. So the only combination of these 2 drugs together, I leave on the table for patients in status. How do you remember that? It's kind of cool. So remember that these 2 drugs really block CNS neurotransmitters and activity. How do you remember that? You've given propofol to the bedside. Those patients go in the quote-unquote K-hole and get sedated. Why is that? It blocks the main inhibitory neurotransmitters in their brain. Ketamine, which patients were given when they were escalating for acute psychosis, it also blocks the excitatory neurotransmitters in the brain. So the combination of these two, excitatory and inhibitory, block any type of seizure activity. So ketamine, propofol together should be on the table for status, and that's my personal opinion of just leaving that. Patients in status are rarely ever hypotensive. Back to this article. This made tremendous headway in the airway literature, so let's just kind of break it down and put it together. I quoted the article, ketamine reduces mortality compared to etomidate. Well, they looked at critical illness, and they looked at these patients that were intubated pre-hospital, in the ER, and in the ICU. People that do pre-hospital medicine don't kind of like that because they're in a different world than we are, and I honestly don't think you can compare those two very well together. I'll leave that alone. Their outcome was all-cause mortality at the longest follow-up available. I have great respect for patient care and my colleagues in the ICU. Longest follow-up available doesn't equate to emergency medicine to me. I'll take it down even further. There are secondary outcomes. Let's look at this. They looked at SOFA scoring, which is GCS, to renal clearance. They looked at ventilator and pressor-free days a month after intubation. I don't know where that sits in our world, but I'll leave that alone. They did look at post-intubation maps, and they looked at success rate of first pass. First pass is dependent on the intubator, and the story had to be. What wasn't is most of these patients were septic. None of them had COPD. None of them had an intracranial hemorrhage. None of them had heart failure. Trauma patients were included in the studies. Critical care septic patients are much different than critical care trauma patients. Why do I say that? Trauma patients are either obstructive or vascular as a compromise. Septic patients are not. So I don't think you can compare the two very well together. And they looked all the way to hospital discharge, a month after the patients were given ketamine or etomidate. Okay, so peri-intubation also in these studies didn't look at what other drugs they were given. It didn't look at opioids, it didn't look at what paralytics were given, and it didn't look at what pressors were given. So I don't know where that really stands, and you can't make a blanket statement of all septic patients because of that. Who knows? So my question to you is this: how does a single dose of an induction agent affect 28-day or up to 30-day mortality or even hospital discharge? You guys know that this doesn't work. Why is that? Its half-life is too short. All of you have given propofol and ketamine at the bedside and even etomidate, and what did you do when you were done? You sent them home. So let's go back to these studies that look at these patients. The 28-day mortality isn't really part of our world or our thought process. Dropping somebody's blood pressure is, I don't argue that. So making this significant mortality decrease as a single agent is almost impossible to say as a blanket statement for all critical care patients. And we require an enormous sample size at all of those variables that we talked about. Okay, so my question to you is making articles that look at critical ill patients is a huge study that would need to be done, and it has multiple variables and be very hard to predict. Bottom line, this article suggests that ketamine is a better agent, and that's really what it does. It suggests that maybe in this 28-day mortality that ketamine may have been better. I still can't tell you that soundly. So the pendulum is still swinging. So making this blanket statement in this subgroup is very difficult. Okay, so bottom line, this debate continues. So that pendulum I gave you continues to swing. I can't tell you one drug is better than another. You're going to have to do that, and I'll show you how you're going to do that in hopefully a minute. Critical Care Medicine 2023, I said, let's go to the source. This is Society of Critical Care Medicine Clinical Practice Guidelines. This just was published last year. What do they say? They walked away with two key clinical recommendations for these guidelines. Number one, there is no difference between etomidate or ketamine as an induction agent. And more importantly, that the incidence of vasopressors or peri-intubation periods through hospital discharge didn't change it either. So in this pre-intubation, peri-intubation drugs that you give, either one of these drugs would prove not better than each other. So Society of Critical Care Medicine does not state one is better than the other. I love that. That's the source for critical care medicine, much better than I am. They've reviewed all these articles and the data. Number two, they're against administering steroids in patients that receive etomidate because the data happens to be so weak about that to say that. I looked at all these articles when this first came out. Dr. Sutherland and I actually looked at it. You would need to do levels pre and post etomidate to know if they were adrenally suppressed or not. And many patients that are septic have a higher level of steroids because of the stress of that. So who knows where we sit with that? So I'm against that if you gave etomidate in itself. It doesn't make much sense. and it's not recommended by Society of Critical Care. Okay, here's the deal, team. Induction agents are nuanced with many factors to consider. There isn't one that's better than the other, right? And all these patients, when you're considering which one you choose for intubation, is your clinical choice, not necessarily one article's choice, right? I love saying this. So we accept that a single antibiotic will not eradicate all bacteria, but yet we wish or hope to find one single agent for an RSI induction. That can't happen. That's the bottom line of this. I don't have an answer for you. You're still on the pendulum that's swinging. And here's the deal. If you really look at what's evidence-based medicine, I love this slide. Look at this. The scientific evidence, maybe from these articles, is on the top right in red. Your clinical judgment is just as important, and also the patient's values. So there isn't a one answer. So let's just review this. Ketamine versus etomidate, the pendulum still swings. I personally think that non-depolarizing agents are much safer. All of the residents here know that because of the risk of many things, but most importantly, the duration of a non-depolarizing agent will benefit you in a failed airway. Induction agents, vasopressors, there is no particular answer. It's your clinical choice and your bedside choice. Done. Thank you, Mike. Appreciate it.
Thanks, Dr. Butler. Let me have you stay up here for a moment. We have a few questions. I want to thank Dr. Gabriella Miller for manning the chat as well. And Dr. Miller, I think, has one or two questions that have come in for Dr. Butler. I think that would be great. Try to call you up to the podium here while during the break, we're going to try and troubleshoot the mic.
I'm just glad I didn't wear scrubs today.
Sorry, you look great.
Thank you. So I have a question from Joshua, and he appreciates your discussion, and in particular, relative to your comments on paralytics. He's curious to know sort of what your sense of patient-oriented outcomes related to preference of paralytic is. He commented that, obviously we had the strong one related to TBI outcomes, but he seems to think that his review of the literature suggests that most of the contraindications for one paralytic refers to a lot of theoretical risks and not patient-oriented outcomes. He was wondering whether you could talk about your experience, your review of the literature in that perspective.
I like the question. Did you all hear the question? So I think I'll put this into two perspectives. I'm spoiled here. I practice inner city medicine. I have residents who are extremely knowledgeable. I have access to labs. That doesn't happen in the real world. I'm lucky that I've been out of this country to see how people have nothing to start with. Where am I going with this? So the question really comes down to choice of paralytics, which makes sense to me of which one is better than the other. But the bottom line, which sucks, was if you looked at it carefully, yes, it bumped up their K, but those patients were never acidotic or hyperkalemic. Take that off the table. You have no access to labs. But the most important thing I say about choice of a non-depolarizing agent is its duration. That benefits you. You fail the airway in someone that gets rocuronium or vecuronium, so be it. You can bag that patient with ease. You can hopefully put in a supraglottic device with ease. And if it comes to doing a surgical airway, the patient's still paralyzed. That's the benefit. And more importantly, I think pulmonary would chime in and agree that you want the ease of ventilations when you put them on the vent. I don't want the patient waking up, bucking and biting the vent when I'm trying to equilibrate ventilator settings. That window or that 30 minutes is key in getting the patient stable on the vent. Sure. Sure. You okay?
Absolutely.
Okay.
You're doing great.
All right. So Jen and Gaius both had questions about Ketamine. And so Jen in particular was wondering what your dosing regimen is, whether you keep the same induction doses for both ketamine and propofol, or whether you do dose reduction.
Okay. So the question is about Ketamine. Ketamine was very popular when I was a resident, believe it or not. So we said, okay, let's take the propofol and ketamine. We worried about dropping the blood pressure with propofol. The ketamine will abort that. The bottom line of the literature said this: Ketamine was not any better than using either agent individually. So, and nurses don't like that because of mixing those two together. So the doses can remain the same, but you have to be careful about aborting the side effect of the other. I kind of don't use Ketamine, and it wouldn't have a realm in RSI. It just wouldn't, because now you're muddying the waters with two drugs versus one. So I would take that off the table. Maybe if you want to do that for bedside sedation, I'll take that off the picture. But for RSI, I would say no.
And then there's a question about combining rocuronium and ketamine. It seems to be an emerging trend. Yep, so there's a question regarding a combination between rocuronium and ketamine and whether there is a specific synergistic effect with those two agents, although sort of one's an induction, one's a paralytic agent.
Oh, great. So I have never heard of a synergistic effect. They're two totally different drugs. So giving a non-depolarizing paralytic and ketamine, giving a paralytic can drop your blood pressure. Maybe that's what these people are doing, giving that as a ketamine chaser. But putting the two together or mixing those two in a syringe, I would be careful about that. So I've not done that. The issue was to give a paralytic first and then your induction agent because of the time of onset. But that proved not to be standard in the literature either because patients initially that were given a paralytic somehow lost their IV and then became locked in. So I would not recommend doing that. Makes sense if you look at pharmacology or onset, but doesn't make sense clinically.
That's our last question from the chat so far. Thank you, Dr. Butler.
You're welcome.
All right. Any questions in person for Dr. Butler? All right. Well, I want to thank everyone. We're up on our